Hello, everyone, and this is Dr. Carrie Bedient from the Fertility Center of Las Vegas, joined with my two absolutely splendiferously splendid, superiorly superb co-hosts, Dr. Hudson from Texas Fertility Center
Hello, everyone.
and Dr. Abby Eblen from Nashville Fertility Center.
Hey, everybody. If only all that were true, Carrie. I wish.
It totally is. What are you talking about? So, for our listeners at home, this is a slightly different episode than normal. We are participating in the Fertility Rally Live event. And so, Fertility Rally is a group that is safe, all inclusive for anybody who's going through the roller coaster of infertility or building their family through ART, the assisted reproductive technologies. It's a 24/7 community that provides lots of content and education. They have a really badass membership that just get it. And so what we are doing today is we're answering a bunch of their questions and participate in that event. So we are very excited to be doing that. And because we are in a slightly different setup this time, we figured we should probably actually introduce ourselves because many of these people aren't necessarily regular listeners yet who know us. So, all right, Susan, go for it.
All right. Well, I am Dr. Susan Hudson. I am from New Braunfels, Texas. It's actually where I was born and raised. I was able to come back here after I did all of my training to provide fertility care. I am a Fightin' Texas Aggie and went to medical school and undergrad at Texas A&M. I did my training at Scott and White in Temple, Texas, and then went to fellowship at Mayo Clinic. And my professional career after that has all been in the Central and now South Texas area. I have a clinic down in Corpus Christi, Texas. And I love everything having to do with fertility. I love being able to talk with individuals and couples and figure out the unique situations that are going on and be able to help people go through their fertility journey.
All right, Abby.
So I'm a native of Tennessee, East Tennessee. I live in Nashville right now. I did training at the University of Tennessee Center for the Health Sciences, which was in Memphis and a far different part of the state, far away from me now. I did residency training at Shands Teaching Hospital, University of Florida, and then I did fellowship training at the University of Louisville. I stayed on faculty there for a few years, and then I've been now in at Nashville Fertility Center for about 21, 22 years. And like Susan said, I really enjoy what I do. It's just amazing getting to be part of helping people grow their families and just, seeing, sometimes we see patients that, maybe had baby number one, and then come back for baby number two, baby number three. And it's just really fun being a part of family building for everyone. So, so appreciative of those patients and just appreciative of being part of this rally.
And I'm Dr. Carrie Bedient. I'm at the Fertility Center of Las Vegas. And so I grew up in Arizona and did med school at the University of Arizona after doing undergrad at WashU in St. Louis, and went to Cleveland for the Cleveland Clinic for my OBGYN residency, then down to Atlanta for fellowship at Emory, and have settled in Las Vegas with my family, and love it here because it's just a touch cooler than Arizona, but it's got the same view of mountains and desert. So I'm very happy here. And I went into fertility because I love taking all of the really complex science and explaining it to people who don't necessarily have that kind of background. The more crazy analogies, the better. And so I love what I do, in part because our patients are really healthy. And so it's really fun to be able to take something that's such complex science and apply it to people who really need it in order to help their families. So, all right. So we are super excited for this because question episodes are always really interesting for us, not only because we get to see what patients are thinking about, but because it's a good opportunity for the three of us to cross-check, well, what are you doing?
Exactly.
How do
We
you
learn
approach?
from each other, don't we?
I always say there's an art to art. So, and sometimes we figure out there's a different palette to use.
Yes, yes. So we're going to start with the general questions first. We've got some general questions and then some case-specific questions. So starting with the general questions, what are the main differences in programmed versus modified natural frozen embryo transfers? What makes a patient a better candidate for one or the other?
So I think the first thing to kind of talk about a little bit is what are the differences. So when we're talking about a program cycle that's generally using estrogen, estradiol in some form, whether it's going to be pills, patches, injections, lots of different ways to do that. You usually do that for a few weeks, and then you would add in some progesterone at a very specific point in time, timed for the time of when your embryo transfer is supposed to happen. Whereas a modified natural cycle, usually most people are going to use some oral medicines like Femara to help recruit follicles. Hormone levels will be measured, and then the lead follicle will be triggered at a certain time, and that trigger is going to determine when the actual embryo transfer is going to be, instead of it being a more set date and time.
And one thing I'd just like to add too, I mean, Susan really hit the nail on the head, kind of explaining it, but a lot of patients think that we all have the same recipe book for what we do. And, basically what she said, a program cycle is estrogen and progesterone that we add back, as opposed to, and I call it, I don't know if it's a natural cycle or modified natural, but bottom line is oral ovulation induction. And then generally I think we all like to replace progesterone. We don't like to leave that to chance. And so really that's the big difference. I mean, but there's different tweaks and different medicines you can use. Some people use vaginal medicine. And so I think sometimes patients think that there's just one way to do it, and there's multiple different ways to do both.
One of the biggest things about a modified natural cycle is that you're building your own corpus luteum. So once the egg releases, that space that it releases from is not just a garbage can. It's a very functional space. And so it goes from being a little factory of building the egg and making estrogen into a factory that produces progesterone and estrogen now that the egg is gone. And so the thought is maybe there's some additional growth factors or hormonal support that's coming from that science hasn't identified yet that may be beneficial. Now, the pregnancy rates between modified natural and program cycles typically are not hugely different. And so what you do in part depends on what works for you and your doc, because all of us have our preferences for certain patients. And so really oftentimes the most helpful thing to do is what your doc is most comfortable with, because there's a reason they're most comfortable with it. Some people cannot do a modified natural cycle. Someone who does not have cycles of her own for whatever reason, ovarian insufficiency, menopause, has any sort of
Ovaries.
no ovaries, hypothalamic amenorrhea,
Yeah.
any of those things where you can't make a follicle on your own. Some PCOS patients are resistant to the oral medications. In those cases, you cannot do a modified natural cycle because you can't get the natural cycle part. But other than that, I mean, most people are pretty fair candidates for either.
And I agree with what Carrie said about, which one's the best, is that realistically about every 18 months or so, we get another study right now that says, oh, this one's a little bit better, but then the next one says this one's a little bit better. And so it really probably more depends on the patient population and what you're skilled at doing. And I agree with kind of doing whatever I mean, in my practice, there's some doctors who do almost all modified natural cycles, and there are some doctors who do almost all program cycles, and there's some people in the middle. And quite honestly, we're all pretty darn good at getting our patients pregnant. So the actual formulation, sometimes one or the other may work better on somebody, but for most people, it's probably not a big breaking point.
Some people with the modified naturals, if they have a history of hormonally sensitive cancer, especially breast cancers, sometimes they'll opt for those. But truly, your hormone levels go so high in pregnancy that the extra 2 weeks of a natural cycle, having lower hormone levels for that is purely to make you feel better. It's going to have really very little impact on anything that happens after, because you're about to go through 9 months of crazy high levels. And so those extra 2 weeks don't really make a difference.
Well, one other thing, which is fairly minor in the whole scheme of things, but generally when you do a modified natural, you never quite know when your day of transfer is going to be. So if it's really important that your doctor do your transfer, they may not be able to be available on whatever that day is. So that would be the only other thing that's a little bit different about a modified natural. You just can't predict when you're going to go to transfer.
Or if you're traveling for transfer, and that makes a difference as to when you
Yeah.
catch a flight to be near your clinic. that really impacts it too.
All right. What's our next one?
Next one, why are preeclampsia and other complications or issues such as subchorionic hemorrhages so much more prevalent in IVF patients? This is a good one.
That's a great question. We don't really know. I mean, we think for some reason the placenta, I don't know, you guys may know, but for some reason we think the placenta doesn't implant as well if we put an embryo in. And I don't know that anybody really understands why. I don't think it's a huge widespread thing, although we do, it is true that there are more placental issues in patients that have, that do IVF, but generally it's kind of one of those things that there's not a lot we can do about it. Now, in some patients, we will give you aspirin, and that can be helpful to minimize your risk of that. But it's kind of one of those things. Most people don't sign up and do IVF electively. They do it because they can't get pregnant any other way. And so it's just one of those things we have to kind of deal with. But I think the majority of people do very well, and those risks are kind of minimal.
I agree with that. I think there's probably a little bit of evidence that we're just talking about those modified natural cycles that may decrease your risk. So if you have a history of severe preeclampsia, especially with some of the big complications like HELP syndrome or something like that, that could be lean, you and your doctor to doing that type of cycle. But we know that a lot of it also is the nature of the infertility, that people with infertility that who even spontaneously conceive are still going to be at increased risks of pregnancy complications. And so it's a little bit of the chicken or the egg type of thing as well. Is it the nature of the infertility or the fertility treatment itself? And I think there's kind of growing evidence that it has more to do with the underlying nature of what we're working against.
When you have people who are undergoing infertility treatment, oftentimes they skew a little bit older. So they have had a few extra years to accumulate insults to their body that may not make them out and out, hypertensive, have high blood pressures all the time. But when you put the added stress of pregnancy, that's enough to tip them over. So that's part of it. And when you look at some of the other complications, subchorionic hemorrhages, for example, patients who've had IVF get monitored far more closely than someone who gets pregnant on their own. Because when you have IVF, within 10 days of that embryo going in, whether or not it's stuck. So you're getting monitoring at a much, much earlier phase because we know exactly when that sac should be showing up and when we should be seeing a heartbeat, and you better be damn sure we are looking for it. And so when you look for things, you find them, and that includes subchorionics and early miscarriages, biochemical pregnancies, because a lot of women don't recognize any of those. They see a little bit of spotting in their periods, maybe a little bit late, but otherwise seems normal, and they don't recognize all the things that have maybe happened. So we think that subchorionic hemorrhages are probably relatively equal in the regular population. It's just we see them more because we're looking more. And IVF patients are really smart and they're very on top of their healthcare, which is fantastic, but it also means stuff gets picked up. And so you see a lot of those complications. All right. So next question.
Mhm.
For what situations do you recommend consultation with a reproductive immunologist? Is it worth it?
I would say that in most situations, the things that have good evidence with immunology are going to be covered by a reproductive endocrinologist. And so if you're going to a reproductive immunologist for things that are more on the periphery, um, I would say in general, the data probably isn't as strong to actually support that testing and those treatments, because otherwise, those of us who have done training in reproductive endocrinology would be doing it ourselves.
Yeah, I would agree with that. I just, there's some things that can be tested, but a lot of things like treatment with IVIG were something that we talked about 20 years ago, but those have sort of not stood the test of time. And, and if patients have recurrent pregnancy loss, we're all looking at all kinds of things that potentially could cause an issue because we want people to do well. But unfortunately, a lot of the things that are done testing wise are really not things that are supported by, studies that really say that it makes a difference, or like Susan said, we'd all be doing those things. So we wish there were more things that we knew to do for the immune system, because we know the immune system is very important in pregnancy, but unfortunately, there's just not a lot of tests out there that really guide us.
Things that have been have been proven with the test of time stick around. Frozen embryo transfers, for example, those were very clearly demonstrated to be have higher success rates, and they have very consistently stuck around since that was found. Reproductive immunology goes in and out of phase, and right now it's very much in phase. It's getting a lot of publicity and press, but like my brilliant colleagues have said, anything that we can find solid data for, we're jumping on, because everybody would much prefer to make a positive pregnancy call and look like the hero, especially after a bunch of losses, than not. And so if we can reasonably do it, we do. But we want to go on things that are data proven, because otherwise it's very expensive, not just financially, but physically and emotionally, to go through things that are not necessarily proven as well. All right. Can you all opine on how you think IVF will be impacted by the current laws being passed and by the general election? Is IVF safe? We know you're all in different states and are affected differently. True story. All right.
Story.
Who's going first on this one?
Well, in the state of Tennessee right now, our trigger laws say that if somebody's pregnant with a baby in their uterus that has a heartbeat and somebody removes that pregnancy, that's considered as an abortion. We don't ever put embryos in the uterus and remove them. So for right now, what we do in terms of creating embryos in our lab, making embryos, freezing embryos, and even, ultimately the decision is made by patients, but if patients choose to discard embryos or abnormal right now, there's no issue there. We don't know when the Tennessee state legislature meets again, if there'll be some new law. But for right now in the state of Tennessee, we're protected, but that can change with every new election cycle. So vote what you think, because that can make a big difference down the road for all of us.
I would say in Texas, it is similar. I think that, I don't, is Tennessee more Democratic or Republican at this point, Abby?
No, we're red.
Okay. So, I would say even though Texas is pretty conservative, those conservatives tend to still appreciate the nuances that delineate issues with embryos and IVF and what is happening with abortion laws. And so right now, I don't think, we can only deal with what we have here and now. And quite honestly, we have a lot of patients who call in who are concerned about exactly these same things. And just like everything else in life, you can't worry about the what ifs. Okay. What we worry about is the what do we have at this moment and how can we help you achieve your family? And I can say in Texas, we can use IVF to achieve your family. We can store your embryos. We can discard your embryos if you so choose. We can have embryos in storage. No matter what happens, I don't think anybody's ever going to be in a situation where they're ever forced to use embryos. That is just, I think, outside the realm of anything that would happen in the United States. That's not,
We hope.
no one's going to force you to use your embryos, no matter what a law is. They may dictate what you can or can't do with your embryos for disposition. I can say that through our network, the Ovation Network, our embryos in long-term storage, fortunately, are in the state of Nevada, which Carrie can speak of, and that from my understanding, Nevada laws are very embryo protective, and the only way to change those laws would be under very, very huge. There would have to be a huge majority of the population to vote for those changes to happen. So at this moment, I would say rest assured, worried, let's worry about helping you get pregnant and not necessarily worry about those types of things at this moment.
So I'm very fortunate in the place that I live, and that women's healthcare is protected and delineated as being protected. And so part of the reason why we bring up all the abortion issues is because abortion and IVF are different ends of the same spectrum. And so much of the personhood movement, where the thought is that as soon as a sperm and an egg meet, that is a human being, really affects what we do, because of course that's embryos. And so right now in the state of Nevada, women have the right to make their own healthcare decisions. And so we're really pretty protective, and there's very active movement right now to further strengthen that and to delineate IVF specifically included in all of that. And so it would take overturning the state's constitution, which requires a couple of votes and is a very unpopular thing to do, because regardless of which side of the aisle you're on in Nevada, nobody wants legislators touching our bodies in any way. And so as a result, whether that's a very liberal, you can't take away women's rights, or a very conservative libertarian, it's my body, don't you dare make a decision for me. Both of those things happen to streamline here. So it is very fortunate that the, ovation storage is all here, because it's very protected. There are sanctuary laws, so people who come here for whatever kind of healthcare, within the state, we're not obligated to help another state criminalize and prosecute a patient who comes here for healthcare. And so I am very fortunate in where I live that unless there is a federal law, my job's pretty safe.
What else we got?
All right, so now we're going to start some case specific questions. So this patient is age 44. She has 2 embryos left after a failed FET. PGTA is inconclusive. What should she do now?
Ooh, that one's,
Yeah.
the reason why I kind of make the little scrunched up face for those of you that are watching us on YouTube is because there's definitely 2 sides of what you have to pay attention to here. Though we know that doing a single biopsy really doesn't harm an embryo, there is growing evidence that doing multiple biopsies may not be a great idea. Most embryos are going to be fine, but it may decrease the likelihood of that embryo making a baby down the road. But at 44, the chances of your embryo being chromosomally abnormal is probably over 90%. Okay.
Mhm.
And that's a pretty conservative 90%. So it's probably higher.
Yeah.
And so I think a lot of it has to do with where you are in your heart and in your mind. If you do an embryo transfer and you know that there is that high a chance that it's going to be chromosomally abnormal and you're okay with that, versus somebody who may want the reassurance of, I don't want an embryo transfer. I want the embryo that's going to give me the highest chance of pregnancy. And I don't want to go through all the stuff of an embryo transfer or the price of an embryo transfer. Then rebiopsy may be the right decision for you. But I do think especially over the last year, we've gotten some more evidence that is more of the case. So a lot of this is where your heart meets your mind, because there are definitely risks on each side. And knowing that there's a very high likelihood that you're transferring a chromosomally abnormal embryo, some people would take that for a pause.
So I would say back in the day, several years ago, before we did genetic testing, I mean, we were in this situation a lot. And so I would definitely transfer 2 embryos, because, I wouldn't transfer one at a time, because like Susan said, pretty unlikely that both of them are going to be normal. In fact, pretty likely they both will not be normal. So I think anybody would agree it's fine to transfer 2 embryos. So that would decrease your money and, your cost and just efforts in doing 2 different cycles. If you were my patient, yeah, I agree with Susan. I was going to say, if you were my patient, I would say biopsy, but I wouldn't necessarily say that, I don't think. But I do agree that there's a real high likelihood that they're both abnormal. So I would definitely transfer 2 if I do a transfer.
I think it's worth considering whether or not you want to do another retrieval now, because let's say, for instance, you transfer those, you have one that doesn't stick but does result in a miscarriage. So at that point, you're burning at least another couple of months waiting for everything to resolve. This may be a situation where you decide, hey, I want to do another retrieval and see what I can get. And at that point, you can revisit, does it make sense to rebiopsy these embryos or not? I would agree most of us are not real fans of biopsying an embryo for a second time, but inconclusive just means it's not tested. And so it doesn't mean it's bad. It doesn't mean it's good. It just means it's not tested. And so I agree with the others about it's really how you would approach an abnormal result. And where you live, where you are mentally, where you are physically, all of that is going to play a huge role. And that's going to be a very different answer from one couple to the next.
And when Carrie's talking about doing another retrieval, it's also a time to think about, if this is not successful, do I want to continue trying with my own eggs?
Yeah.
Or is this the point that I may, which it's the right thing for some people, it's not the right thing for others, may start to consider things like donor egg or donor embryo.
Mm-hmm. All right. So next question. Advice after a failed first retrieval that resulted in no normal embryos. Is there any hope? That's all the information I have.
Yes, absolutely. I've had countless patients who have done poorly for whatever reason. Either they didn't have normal embryos, and like Carrie says, it's like pulling the lever on the slot machine. All bets are off. You never know what you're going to get the next time around. So absolutely, I would definitely do another egg retrieval. If emotionally you think you can tolerate potential of bad news again, if financially you can tolerate it, but if you're just looking completely unemotionally at everything, I would say absolutely. If it were me personally, I would definitely do it again, because you don't know what you're going to get, and you may have even a couple that are normal. Who knows? So I would definitely do it again.
I think that most of us would say that doing another cycle is, especially if money is not an object, if you have insurance coverage or whatever, is, it's always a reasonable option to consider. But this is definitely one of those things where you want to sit down with your REI, because, I always sit down and say that IVF is not only therapeutic and that we're helping you get pregnant, but it's also diagnostic. There's some things that we just don't know until we see eggs and sperm in a dish. And so you can very easily sit down with your reproductive endocrinologist, go through your stimulation. What are the things they saw in the lab? Did we have failed fertilization? Did we have embryos that didn't grow? Were they all chromosomally abnormal? What is your age at this point in time? I mean, honestly, if you're 28 versus 44, that second cycle is probably going to have a vastly different number attached to it on the likelihood of success. And there's so many intricacies of that, that really sitting down with your doctor and going through step by step your stimulation, what happened in the lab, what happened with your chromosome testing, that will help you lead you to the right decision for you.
I think that ovaries are entitled to have a bad month too. And I see this most clearly demonstrated with egg donors, because you'll have an egg donor who goes through 4, 5, 6 times, and majority of her cycles are going to be awesome. And then there's just one where it's crappy. And you know full well that she's doing it right, and she's good at going through this, and her body knows what to do. And you just don't get great embryos from that particular cycle. And so the problem with doing IVF with someone who's trying to get pregnant with their own kids is that most of the time you just get one cycle. This is not a donor situation where you're going to go through multiple times if you can avoid it. And so dealing with the emotional fallout is oftentimes more challenging than dealing with the physical fallout. Like, your body's going to feel normal within a couple of weeks for the most part. And so you can handle that. It's more the fear and the concern and the anxiety of what happens next. And so, I agree that if you pull the emotion out of it, yeah, do it again, and talk with your doc, because they may be able to point out things, and this may be enough to say, hey, all right, fine, we are really going to stop smoking or drinking, or we're going to do this or that, or whether it's losing weight or it's getting some medical condition fully treated. Maybe those things make a difference for you, and so the next journey is a much happier ending.
Yeah, and regardless too, your doc is probably going to tweak some things in your cycle. I mean, I think all of us agree that almost never do I send a patient through and do exactly the same thing again. We always want to make little tweaks and little changes, and sometimes those tweaks and changes can make a big difference. So rest assured, if you go through a second cycle, I know your doc will make some of those changes.
Agreed.
All right. I have 3 miscarriages at 6 weeks, 1 live birth, and now 1 failed PGT tested FET. Where to go from here?
Well, I would say we definitely need to make sure you've had a recurrent pregnancy loss evaluation. So making sure both you and your partner have normal chromosomes, because even though you have a PGT tested embryo, sometimes there are some things that can be missed on PGT. I would make sure that you've been tested for antiphospholipid antibody syndrome, or APLS. It's just a blood test. but it's a very important one. And of course, making sure your thyroid and your prolactin level are normal. Kind of piggybacking onto the last comment that Carrie made, that sometimes this is a time that making lifestyle modifications, if you use any nicotine, you or your partner, that needs to end. If you have some struggles with obesity, this may be a time to work on getting your weight down to a lower level, because we know that there really is a big difference in pregnancy success rates and miscarriage rates when we have BMIs, especially over 30. So those are some things that I would want to make sure are I's dotted and T's crossed.
Yeah, and there's some other things that we can do, and honestly, there's not great data for those, but I think maybe it just makes us feel better. But sometimes giving additional progesterone can be helpful. It doesn't hurt to give you more, so we tend to do that. Sometimes giving you things like an aspirin to improve blood flow to your lining can be helpful. And just recently, we talked to Dr. Bruce Leslie, who spent his whole career looking at implantation failure. And he also suggested, there's sort of some older studies that have suggested this, and some new information has suggested something called corpus luteum rescue, where you give a trigger shot and then a week later you give another trigger shot. It's pretty cheap. It's like $50 for each of those shots. And sort of the idea behind it is it may help the corpus luteum that we talked about earlier that produces progesterone. It may rescue it from actually becoming atretic and going away. And it's almost like putting water on a dying plant. It helps the plant start to grow and continue to develop. So things like that sometimes can be helpful. And was a really old study that showed just tender loving care, seeing your doctor and having somebody, watch over you and be part of the whole situation. Just that reassurance. Actually, in one study showed that patients that had that extra care tended to do better. So certainly talk to your reproductive endocrinologist.
I just want to make a comment though about the rescue HCG injection, especially for people who have recurrent pregnancy loss. Realize that if you're taking that second HCG level, if you're peeing on a stick exactly when you're supposed to be having a positive pregnancy test, it's probably going to be positive, and you're not going to know exactly if that's a real pregnancy or the HCG level falling, or if you're watching HCG levels falling, if that was a pregnancy that's failing, or if it's just the HCG that you injected leaving your system. So it is something that might help, but it is something that you have to kind of mentally prepare for. Because if you go in for bleeding and you have a positive HCG level and you're like, oh, it's 50. Well, is it 50 going up, going down? And what's it actually from? And that's going to take some time to figure out. And I've seen some people really kind of struggle with that part of the process as well.
Good news is you've had one live birth, and that
right.
makes you far more likely to have another one. And so obviously we can't predict, is that going to be with the next attempt or, 12 attempts down the road? But it is a carrot to help keep going and say, all right, well, it happened once, that means it can happen again. And so let's keep giving it a shot, as long as that is a reasonable decision for you as a human being, and what you can handle, tolerate, and take.
Another thing, kind of back to Dr. Leslie, is there's some evidence that the chemical BCL6, which is related to endometriosis, if it's present, it can also potentially increase the risk of miscarriage and implantation failure. So potentially having a test to look for that, if it's present, and then you can treat it, may improve your outcomes later on.
Mhm. All right, embryo glue, pros and cons.
Embryo glue is something that I have actually never used in my career, because right when I was coming in, I think was when it was like a big thing and then it faded. So I would say that's probably a technology that should be and has been out the door.
Yeah, I think it's been out the door for a long, long time, unfortunately. I mean, fortunately, yeah, we haven't used it in a long, long time. It was a great idea, but it just didn't work.
It's media with slightly higher protein levels, so it's probably not going to hurt anything, but also doesn't really do anything either. And so whenever you change out of what your lab is used to dealing with, you're introducing a new element of the unknown. And so most of us kind of shy away from that whenever possible, just because we know what works in our hands, and especially when something has no data behind it that's really reliable and stands to the test of time, we try and avoid it. All right. Thoughts on growth hormone actually helping to get more blasts or increasing egg quality?
So I'm going to talk about my experience. I think the data out there is a little hazy on it. Okay.
I would
Which
agree with that.
I would say it's hazy data. There's not conclusive studies to say it helps or hurts or anything in between. I don't think, in my experience, it helps me get more eggs. I tend, and there's always exceptions to the rule, if I have somebody who's had a bad cycle and I decide to use growth hormone, in those people, I tend to get better quality eggs and more embryos and more chromosomally normal embryos at the end. Um, I tend to use growth hormone on people who have had cycles that things didn't seem to work, or if they're in their 40s, I'm tending to use it more. But it's not an absolute. Okay, there's nothing that's a complete
Nothing's an
magic
absolute.
bullet. There's no absolutes. I think there is the potential that it helps, and I have definitely seen from like cycle to cycle in the same person. And I mean, I actually just have a patient who's coming back for her second baby. We did one egg retrieval. She ended up with something like 8 or 9 embryos tested the first time, and they were all abnormal. And she was less than 35. Like, it was completely unexpected. We did a growth hormones one, and now we have like a ton of embryos. And she was actually the first person that I started using this in. And so again, it's anecdotal evidence. It's not a silver bullet, but I think it can have the potential to help some people.
Yeah, I would say personally, I've had, limited experience with it, but it's kind of gone both ways. I've had a couple of people that have done really well with it. I've had a couple of people that it hadn't done anything. It's expensive. I do use it in some cases. In fact, I'm going to talk to a patient this week about using it because I don't have a lot of other great things to try and improve her cycle. And so I do think it has a place and it's helpful for some patients, but it's hard to know who's going to be helpful for, and it's pretty expensive too.
Well, I mean, expensive. The way that there's multiple ways to do it. So there's some people who do a lot of it before the cycle. I tend to use it during the cycle. And so when
Yeah.
I use it, it usually ends up costing about $1,200. So
Oh,
yeah,
okay.
$1,200 is a lot of money, but in the grand scheme of IVF, it's
Yeah.
also not.
Actually, that's better than I thought it cost, actually.
Yeah. I typically use Omnitrope. We get 4 doses out of each Omnitrope vial. Each vial is about um, $400 a piece. So we usually use the 3 vials. So Carrie, I don't think you use it, do you?
I will use it when I've got nothing else to turn to. I have done it in some patients who've done a ton of retrievals, people who are low responders, and I just never saw a difference using it versus not. There are a couple patients where I could argue maybe it was the omnitrope or the growth hormone. When you look at the studies, I think it shows maybe one more mature egg. It doesn't show difference in blasts or ongoing pregnancy rate in the studies. The question is there a population out there that it's really beneficial for? And we just haven't honed down that population.
Mhm.
So I don't tend to go there right away, but it's on the list of things of, all right, if we need to try something new, let's give it a shot. And if it works, fantastic. I'm never going to turn down a good miracle.
Yep. We work
All
on
right.
miracles every day.
Yeah.
Last question. Are the lead follicles during the stim process of IVF typically the best and healthiest follicles?
Carrie, you answer this one.
Yeah, this is yours.
This is Carrie's baby.
So the answer is no. Not always. And when you look at the follicles, we used to think that having you just had to trigger once you hit 3 or 4 big follicles. Now that we do frozen embryo transfers all the time, we can push them much longer and end up with far more good follicles. And so the ones that are the biggest are not necessarily the ones that are automatically going to become babies. When you divide out the groups, the size groups that those follicles come in, and then follow that all the way through to blastocysts and babies, there's actually a decent distribution. Like once you're over about 18 millimeters or so, there's a pretty decent distribution. So it's not always the biggest ones. We know that the smaller ones are less
Carrie,
likely
what are
to
you
heal.
meaning by there's a decent distribution?
So there's when you take the groups of 28 and higher, the 25s to 27
You're
millimeters.
talking about millimeters, and you're talking about the size of the eggs, this egg
I'm talking
sac.
about millimeters, and I'm talking about the size of the follicle. So by the time you hit 18 millimeters is the follicle size, that's when people start to think, okay, when is trigger appropriate? You don't want to do it when you've got 1 or 2 eggs that are 18 or bigger and everything else is smaller, because you're a
Which
lot
is what we used to do.
which is what we used to
We all
do.
did that when we were fellows, yes.
Because you're a lot less
Tiny.
likely to hit maturity in those smaller ones. And a mature egg is a usable egg. Immature is not usable. So what we have done is we've started to push it out so that instead of just a couple of the eggs being larger than 18s and everything else being smaller, we try and get everything bigger than 18, or at least a solid majority. So some of those are going to be 18, 19 millimeters, and some of them are going to be as big as 28, 30 or larger millimeters. And so in the context of this question, which is asking, is it the ones that are 28, 30, that make the best embryos and live births? That's not true. That doesn't hold. You can get as many live births from the 18 millimeters as you can from the 30 millimeters. The nice thing about taking it up to 30 is that you're going to get more that are larger than 18. And so you just have more opportunities to get lucky and get a live birth out of it. All right, wonderful. Well, to our fertility rally ladies, we were very excited that we got to participate in this. So thank you so much to the founders for letting us play with you, because we appreciate it. And if you want to hear more of us, Fertility Docs Uncensored podcast is where we live every Tuesday. And to our listeners at home, we are very appreciative of your love and attention. And thank you so much for listening. Be sure to tune in next week for more. Be sure to subscribe, leave us a review in Apple Podcasts. We'd love to hear from you. We're on Instagram, Facebook, and YouTube. So stop by, leave us a like or a hello.
You can also visit fertilitydocsuncensored.com to submit specific questions you have about infertility. All questions will be answered on the podcast anonymously for our Ask the Doc segment, so don't hold back. We love episode ideas, so let us know what you're wanting to hear.
And also remember, this is entertainment, not to be substituted for what your doctor will tell you. So look forward to hearing from you soon. Bye.
Bye.
Bye, guys.